Hi, I'm Michael Morris. I'm a medical oncologist from Memorial Sloan Kettering Cancer Center, and I'm joined today by two close colleagues and friends. Raina, want to introduce yourself?
Raina McKay. I'm a GU medical oncologist at the University of California, San Diego.
Chris?
I'm a GU medical oncologist in Adelaide, South Australia, Australia, at the Royal Adelaide Hospital.
We're going to spend the next few minutes talking about advances in radioligand therapy that we've seen this year and where we've moved since our last Your Amigos live meeting. So the new news for radioligand therapy, in particular in the large phase 3 setting, so there's been a lot going on in smaller trials as well, is the presentation at ESMO by Scott Tagawa of what's called the PSMAddition study. This was a study for newly diagnosed men with metastatic prostate cancer who had not previously or minimally previously been exposed to hormonal therapy. So they could have had 45 days of previous ADT and an ARPI, but in essence, these were minimally treated. And these folks were randomized with an ADT and an ARPI of their physician's choice to either 6 doses of lutetium given at its standard dose and schedule versus nothing but their ADT and ARPI. Primary endpoint was rPFS. There was a crossover that was built in, so OS was a secondary endpoint. Also, key secondary endpoints were quality of life metrics as well. The results of the trial was that there was a hazard ratio of 0.72 in favor of the lutetium containing arm for rPFS, and a very preliminary and early OS look, which had a hazard ratio of 0.84. The quality of life data didn't look significantly different between the two arms, but there were more adverse events on the lutetium arm, in particular with some of the side effects known to be associated with lutetium, and that is xerostomia and also some cytopenias. So with that summary, I think that leads us to a lot of things to discuss in terms of radioligand therapy, how to optimize radioligand therapy in the earliest disease setting of metastatic disease, and also schedule questions, combo questions, and things like that. So, Raina.
Yeah. I mean, thank you for that background. I feel like this was a positive trial. It met its primary endpoint. Therapy is effective, but there's a lot of open questions around who's the right patient population to receive this treatment. It was an all-comer study, largely with vision criteria for enrollment, but it wasn't sort of a slam dunk at the first analysis, though optimistic. So I think one big question is biomarker and selection. I think another question is around how long do you continue therapy? And the therapy is highly effective. This study is a modern day study with a modern day control arm of what we do in clinical practice today with ADT-RP. ADT-RP is highly effective. The 12-month PSA nadir rate is 75% in the control arm. So I think it opens up the question of, well, is there an opportunity to adapt the dosing? Does every single patient need all 6 sequential doses? And I don't think we really know the answers to those questions, at that same meeting, we saw data that were presented from Capitello of capivasertib in PTEN deficient hormone sensitive disease. At ASCO, we saw the data presented from Amplitude for niraparib Abi for BRCA or HRR mutated disease. So I think the MHSPC setting is complex and kind of begs the question of who should get what. Chris, I know you've been a champion of more personalized therapy. Can we do better?
Absolutely. So I think it's very clear. We now understand prostate cancer better in 2025, and it's many diseases, not one disease. And as you point out, there's PSMA-avid disease, there's disease that is likely driven by mutations and deficiencies in DNA repair, BRCA1 and 2, more succinctly and specifically, and disease that's driven by the AKT activation pathway. So at the end of the day, we need to be profiling our patients by PSMA PET imaging and tumor profiling, period. That's the future. And how do we implement what's the best therapy for a patient? For example, if a patient has a PARP a BRCA2 mutation and a PSMA mildly avid, which would you go? If they're BRCA2 mutant disease and they have a screamingly positive PSMA PET, what would you go through? These are things we're going to have to work out. We're going to make decisions. Now the question is, does docetaxel have a role in this still at this stage? I think I would debulk my patient with bad disease, with chemotherapy plus ADT-RP, or if they've got limited disease, SBRT and an RP, and it's still got viable disease, I would add on one of these new therapies, I think.
I think that, much of what the two of you have just been discussing is a treatment selection for which biomarker question. But I think drawing back to the radioligand universe, Chris, what you're just alluding to is how do you optimize radioligand therapy, and do we know what the right combination? You mentioned specifically docetaxel. There are issues in terms of optimization so that we treat more rationally patients with radioligand therapy. So what schedule should we use? How many doses? There's too many doses after the tumor has started to regress. How do we best do the patient selection and then the combination therapy? So there are so many things to address, not to mention the fact that there are the alphas with both actinium and lead. Now there are Auger electrons with terbium. I guess I would ask both of you, there's so many combinations possible with so many radioligands and so many sequencing studies. The two of you are leaders in terms of designing phase 3 trials. So how are you going to select the most promising, because we don't have the resources to do everything, the most promising sequencing and scheduling studies and in which population would that be?
Yeah. No, I think it's a very good question. And I think, as you said, we cannot do every single combination in every single context in every single study. I think the biggest question is who should get it? Can we identify what is an optimal predictive biomarker beyond just vision criteria? And is there a role for designing a study around that? Certainly in the CRPC setting, we have the reciprocal study through the cooperative groups, which is about to activate. This study is looking at patients in the PSMA4 population that are excellent responders to lutetium, and then randomizing them to adaptive dosing with a staggered schedule versus just every 6 weeks. When that study was designed, there was also people that were not great responders. And what should those patients get? Should they get chemo or continued lutetium, or what other escalated therapy? So I think predictive biomarkers, or designing a study that integrates a predictive biomarker to optimize the disease benefit. And then I do think that the schedule question hopefully will be answered in the context of the reciprocal study, but we need to figure out what to do with the non-responder or PSMA low group.
Chris, I think we only have like 30 seconds left. You have the final word.
Yeah, so I think I'll take a step back. I think early CRPC are patients who do not achieve a PSA nadir of less than 0.2, less than 0.1. So I would say let's use therapies we have and optimize them. Docetaxel front loading or SBRT and radiation to the prostate. Induce a remission. Give the synthetic lethal strategy. And if at 12 months, for example, they're still not having a PSA less than 0.2, then I think they should be opportunities that we think about bringing on new therapies but it's essentially early CRPC.
Mm-hmm. So I guess that could raise questions about, is that optimally where radioligand should be in terms of dosimetry, where you have a minimal amount of disease? You probably would need to move into the alphas for that.
If they have disease that you can image and send your target to your radioligand to, yep.
Very good. I think we have to call it there. It's been such a pleasure having this conversation on what is a really exciting, burgeoning topic with much work to do. And thank you both for your time.
Thank you, Michael and Rena.